Good afternoon, and welcome to Beyond the EMR, revisiting your strategy around patient engagement and communications, a health system CIO production sponsored by MHC. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the founder and editor-in-chief of Health System CIO, and I will be your moderator today. We're looking forward to your participation. You can send in your questions or comments anytime in the Q&A box, and we'll take them later in the program. Just so you see how we're going to spend our time today, first we're going to go about 40 minutes with our main panel discussion featuring Chris Akeroyd, CIO at Lee Health, Crystal Broy, Enterprise Chief Digital Transformation Officer with the Medical University of South Carolina, Dr. Shafiq Raab, EVP and Chief Digital Officer and Systems CIO with Tufts Medicine, and Gina Armada, CEO with MHC, and then we will have our Q&A. So let's jump right in. Big topic and great panel. Chris, you want to start us off with a little bit about your new role, your new organization, and your role?
Yeah, thank you. Yeah, and good morning, good afternoon. Chris Akeroyd. So as mentioned, I'm the Chief Information Officer now for Lee Health. Lee Health's in Southwest Florida, Fort Myers, actually to be specific. I'm 4 weeks into the role, so I'm excited to be here. I come by way of Children's Health System in Dallas, formerly as I was the CIO there as well. Lee's an exciting time period right now of great growth opportunity. Currently a $3.5 billion organization, adult and pediatric care both, with great growth aspirations and some amazing opportunity in the growth area of Southwest Florida. So excited to be here and appreciate being on the panel today. Thank you, Anthony.
All right, great, Chris. Crystal?
Everybody, I'm Crystal Broy, and as Anthony said, I'm Chief Digital Transformation Officer here in Charleston, South Carolina. The Medical University of South Carolina is one of the oldest institutions on the East Coast, 200 years of service. We service about 2.4 million. We have 16 hospitals and 2,700 beds, 750 care locations across the state. 5.9 billion total enterprise budget, not just a health system, but also a university that takes only graduate, 6 colleges for medical, dental, nursing, things like that. Very excited to be here and talk about one of my favorite things, which is patient engagement.
All right, thank you, Crystal. Shafiq?
It's an honor to be on this panel with such great leaders and you, Anthony. I work for Tufts Medicine. We are an academic health system in the great Commonwealth of Massachusetts. We claim and we try to serve people with the lowest possible cost. We are known for many things. One of the things that we are known for is, of course, our medical school and our teaching. But we do the highest number of heart transplant in the Commonwealth of Massachusetts, and kidney and other transplants. So we not only provide tertiary care, but we also provide primary care. We have 4,000 doctors in the community who work with us, and we call it a Tufts Integrated Medical Network. We have about 5 hospitals, and we are known for care. And we are committed to not only teaching of doctors and future healthcare leaders, but also we are committed to providing the best possible care in the best possible way. And number one thing that is a very relevant topic today, it's about access, it's about consumers, patients, how do we serve them and how do we go forward with them, and the struggle that we have. So I'm honored to be here. And Gina, thank you.
All right, thank you, Shafiq. Gina?
Thank you. I'm also very excited to be part of this panel today. My name is Gina Armada, CEO of MHC. We're headquartered in Minneapolis, Minnesota. We support global customers across 5 continents, including hundreds of hospital system customers here in the US. And I'm especially grateful to be included on this panel with a couple of longtime MHC customers. So one a customer for 20 years and another for 9 years. A little bit about MHC. MHC is a software solution provider. We deliver document and payment automation solutions to organizations to help them become more efficient, more effective at interacting with their most important stakeholders, their customers, aka patients in this case, their vendors, aka suppliers, and their employees. And we serve as a strategic partner to organizations looking to extend the capabilities of their core systems, such as their EMR, their CRM, their ERP, their HCM, all these large acronyms that we hear all the time. And it's all about how do we help those organizations meet their needs, particularly for outbound communications and interactions where we have to share documents with those key stakeholders I mentioned earlier that require personalization, compliance, reliability, and scale from us. So while core business systems like the EMR manage clinical processing and ERPs are incredible at managing financial processes and so on, MHC's solutions really fill those extend those systems to fill gaps when it comes to generating personalized, high volume, multi-channel communications to get the information to the audience who needs it. So today obviously is about customer communication specific to patients. We also automate use cases in the back office space. So accounts payable automation, employee document self-service, all those kinds of things. But I'm really excited today to hear more about and learn. I get to listen and learn also as a panelist about what's happening in health systems and how to reach patients, because of course, we're all consumers of it. We're directly impacted by healthcare every day. Thank you.
All right, Gina, excellent. Thank you. Okay, Chris, we're going to start with you. How would you describe your current, and I know it's fairly new to you, you're looking at maybe what the strategy is over there, or, you can talk at a high level about the strategy you've been working on at Children's, or you can talk about, how, it's interesting how you come in and getting your arms around what's going on and then deciding, do adjustments need, do I want to make some adjustments here based on my experience? But wherever you want to jump in there.
Yeah, happy to. And yeah, you're right. I'm starting fourth week now, so still in that quick learning phase of all things. And this is actually one of the areas that we've been diving into a lot of how are we engaging patients, and it's so crucial right now. Holistically, the pockets of success I'm already finding is that we're doing a good job at this in more of a decentralized way, and I think that's measured really kind of based on preparedness of the patients as they come in for procedures or as they come in for a visit. And so that I think you're seeing this handled well at specialties. And there's an immense opportunity. We look at this holistically as a platform or a system approach, and how we maybe streamline and standardize some of the ways that we communicate and engage with our patients. And so I think that looking at both sides of that, there is the opportunity to try to get that message consistent and figure out how as a system we navigate patients consistently with a message that is at a higher level and in a regular interval and engaging patients the way we're expecting to engage them.
All right, very good. Yeah, we'll dive into more there. But Crystal, let me get your initial thoughts here.
Yeah, I think the thing that we've been working on is to try to have what we call phygital, things that are the same between digital and physical spaces. So as we engage and communicate, we're doing the same type of things and reaching people where they are, whether it's phone, whether it's text, whether it's email, whether they go to our portal, and when they come to the office and how they're interacted with at a front desk of whatever it is. So trying to get there right where their care journey is and what they're looking for. The difficult thing, a lot of what Chris said, is making sure that the message is on point across all the way. So it sounds like one particular message and not this system and this system. If you think about it, as a patient engages through that life cycle, they're probably touching the EHR and several other vendors, each which usually has, even though it's white labeled, look and feel different. So really working with that to make sure that it looks like MUSC and not like this vendor and this vendor and this vendor, so that the patient provides trust to us because it looks like the same thing. They don't think they're getting spoofed or whatever.
That's interesting. Yeah, things can get deleted. People are very suspicious of any kind of, I mean, the initial reaction is delete, right? If it looks at all weird, delete. So that's a interesting point. Shafiq.
So we have been in the journey for a long time. And when we first started, we were a holding company, and now we are an operating company. So in the life cycle, like Crystal said, is that there is a intake and there is a outbound, inbound and outbound. And then there is a time when there is neither inbound and outbound, and the patient is home or the consumer is somewhere else. So how do you develop that continuity? That's our focus. So to explain that is what we started with, making sure that our decision tree, our appointment, our bookings are accurate. And as the patient asks for us, they get to the right place coming in. Secondly, what we also understood is that when we remind people to come in, also to let them know that, hey, you have a lab test. So normally people just ask them to bring their ID and to their insurance card. We thought it would be nice to also let them know that if it is a blood test or if it's a urine test, is not to void, but to be ready when they get the cup. Because sometimes we miss that as a patient's obligation. Similarly, if somebody's having a surgery, sometimes people say that he should not be on blood thinners. So we try to confirm that before the patient comes, that, hey, it's not only aspirin, there are a couple of other things known as the blood thinners. So we have upped that way. Second, the way we have upped is that we also trying to understand if somebody's looking for a TAVR or somebody's looking for some other thing, they do need some tests before. So we try to take him in and go through the process that you need that. Similarly, we also found from our contact center that it used to take about 6-7 calls to make a remind of for an appointment. So we are digitizing it. That means a mail, a text, a call, and then a human, so that it's not like a robocall, but to make sure that we are also efficient in a more logarithm way. And we're trying to automate it also from our website, from our app. Some people like digital, some don't like digital. So the communication, the most important thing that we are saying to our beloved, the people who come to us, is that when you leave us, we are still with you. That means we are with you in the car, we are with you in the home. We also participate in home healthcare. That also helps. It's not that it does not. And lastly, we are now going towards continuous care. That means if you have a blood pressure monitor and if you have a continuous glucose monitor, other things, so that we know what's happening with you and we can anticipate your care. We're not there yet, but that's what we are working on. So that's what it is, the way to look at it. And of course, we look at our NPSR and other Qualtrics metrics so that we know that we are on the right spot. Lastly, we have engaged patients to be part of our patient engagement committee, and also for the apps that we build, because after all, we are working for the patient or the consumer.
Great stuff. Lots of great stuff in there. Thank you. Gina, your thoughts on what you're hearing?
Well, I think it's inspiring, right? Because we're all on the other side of this as our own consumers and patients of care. And I've both been on the very recent my own experience in a healthcare journey, and then helping loved ones, right? And then it gets even more complicated when you don't have access to your loved ones' information and you still need to try and piece it together. So I'd say what I heard is very inspiring. I think I would agree that crisp and clean communication is really important. I've been in and around healthcare for over 25 years, different areas of healthcare than the provider side that we're talking about today. But communication is essential to everything we're talking about today. And I think I really like the comment about, I'm going to forget your word, your combination of digital and physical, but that is
Oh yeah, what was that, Crystal?
Digital.
Say it again.
Digital.
Digital. You're right. That was good. Go ahead. Phygital.
Yes, that's a great concept, because it's so important when the message is unclear coming from the piece of paper you walk out with the discharge, and I just experienced this myself, versus what I saw in my medical chart, my digital chart, and they don't say the same thing. That adds confusion, right? And we want to reduce those calls. So anyway, very inspiring. I'm excited about the strategies.
So
in
you are
place.
spot on what you just said. Sorry to interrupt, Anthony.
Go ahead.
The world of facts has not ended. If I say they have ended, that is not true. We're all working on it. Second, people do bring things written in a scribbled way. Then we try to type it in and move in. So what I said before, we are working very hard on it. But at the same time, those have not ended yet. One day it will.
Yeah. All right. Yeah. Lots of great stuff there. I have a zillion follow-up questions, but we'll get them in at some point. Okay. Next question. How does your organization decide when a patient engagement function can be sufficiently supported by the EMR versus when a specialized third-party solution becomes necessary? From my conversations, this is one of the core issues that CIOs are dealing with in healthcare today. And everyone sort of has a slightly different angle, thought on it. Um, so a lot of nuance there. But Crystal, let's start with you.
Sure. So the ultimate thing, you want to keep everything in the EHR because it's easy and it's there, right? But they don't usually have the functionality that some of these other vendors have. And while you always look at the EHR roadmap because that would make it easier, most of the time business cannot wait for the EHR to catch up. And if you have specific areas that you're trying to move the needle on, whether it's patient engagement, whether it's collecting copays, whether it's, making sure they register ahead of time to save time at the front desk, you've got to look at other alternatives. And that's how you start to go look for those third-party tools. It depends on the use case. It depends on if you're trying to get rid of patient friction and how quickly you can get speed to value for that. Like how quickly can you install it? How quickly can you move it along so that you start to see the results from the work that you're doing?
Yeah. Excellent. Shafiq?
I think that's a very valid point. The way we think now is that our job as technology leaders are to support our operational leaders and our mission and vision. And the thing is that we are trying to make the lives of our patients better, which is I'm a patient too. And that is true that EMRs are getting better and what they were before. Some functionalities are not there, some are there. So therefore, for our communication to our patients, we have our own app. And our vendors, the front end sits underneath it. So whatever is missing, we have it. Direction to the rooms, or for example, if you want to know triaging, or if you want to do something else. So the functionalities that our leaders are asking for, we can't add if you don't have an app. That's one way of looking at it. Sometimes you need a third party. For example, if you want to scan something, you want to store something, because people bring information in every format. So that is the place where we look for, where we can actually help for nutrition. If somebody needs understanding for dietary purposes and other things that we need for a healthy lifestyle, what do we do? So we need that kind of support, and sometimes we need content that actually will help the patient. So these are some examples, but the bottom line is that we do believe that that there are times when the EMR or EHR is not sufficient. But what we try to do is try to bring the information back in the flow of the patient or in the flow of the provider that's working in it. So it tries to be as symbiotic as possible.
Yeah. Excellent. Very good. Chris?
Yeah, I completely agree with everything it said. I think, it's just kind of highlight a lot of it is the more third-party or point solutions you put out there, the harder the integration becomes. And kind of back to muddying up the water of communication, I think you run a higher risk there of maybe having messages that are incomplete or disparate from other communications that may be occurring. And so I think that's always something to balance. We actually had this conversation here yesterday around where do you balance innovation and early adoption with kind of core mainstream. And and it really comes to you're trying to manage the bright, shiny objects because everybody can come back with all these wonderful vendor solutions, point solutions that solve very specific issues or things, but how does that line up to your strategy? Are those your priorities across your strategy? And if so, I think that's where it makes sense to go ahead and pursue things outside that do advance you in ways that are truly meaningful to the organization. If the risk we run is if we chase every shiny object, we're going to have dozens and dozens upon dozens, I guess, of third-party applications all trying to do the same thing. And eh, I'll give an example of a chatbot. Um, Chatbots have kind of become the thing, at least around here, of we may have two different versions of chatbots serving different purposes. As a consumer or a patient, what's the end result? Am I able to get to navigate to where I need to? Because the complexity of our health systems are very complex. But are these two or three chatbots in your environment really going to give you the same answers or get you to the right point and truly help you navigate that, or are we filling some type of gap that really may not exist? Is a big challenge.
Yeah, it's complicated, right, Chris? Go ahead, Crystal.
I think too, we start out with certain vendors, whatever they are, and we've had some for 3-4 years now, and why they maybe didn't do this before, now they do that too. So now we have to balance which partner we're going to do that with, right? Because
Yeah.
partner A, B, and C now all can send care plans to patients, for example, or education or this. So it's like, when are we using what vendor along the way? And making sure that they know that, no, you can't send because this vendor sends. So we need to talk about the work that you're doing in a different way. That tightrope and balance is important to think about.
Yeah, both of my colleagues have very nicely illuminated this topic of balance. So what I can only add is the following: is that any functionality anybody claims and does, we have a governance committee and physicians are involved in it, patient advocates are involved in it, from bottom to the top, everybody who has to look at it. But our goal is only one, which Chris alluded to in the beginning: as much possible as we stay true to one thing, because we can't confuse our end users, right? So therefore, deliberately, the digital transformation has to align with the service that we are providing to our consumers. So that's why when you're asking this question, you ask, and it can be sufficiently supported. That is not what it is. The way I would like to present is that how can we serve our patients in a way that makes it easier for them. At the same time, the staff and the people who are caring for them, they are all in alignment. Well, there are multiple chatbots. Everybody has a chatbot. And now we have agentic AI that's helping us out. But so most important, we have to create a department of digital medicine. So similarly, separate, sit down and look at things, how they work, whether they are efficient or not, what harm they can cause. But the guiding principle is to be as one as possible.
Mm-hmm.
And I think, Anthony, if I can just jump in for a second. So what you're bringing up is so important, like the multiple chatbots, and it's going to get exacerbated with AI and even the tools powered by agentic AI. That if the source of information they're using is different, the branding, the messaging, the how you position yourselves as an organization, if that source, then you've got the communication divide getting even worse, right? So having that centralized brand, position, messaging, how you communicate, the style in which you communicate to your customers, all that kind of stuff, centrally located or managed or at least understood, I think is a critical component. Otherwise, it's just tools on tools, right? And if they're using different sources, the message will be disjointed.
Yeah, so Gina, talk to me about the different ways you can be leveraging a third party. I mean, there are ways to have a third party attached that probably does seem very different and disparate. And I assume there are integration capabilities where it can seem very similar and like you're not having a different experience, and the data gets back to the EHR, which seems to be a critical element everybody wants here. If you're going to use a third party because they have specialized functionality, it's got to feel the same and it's got to get back to the EHR.
Right. And so there are, and I absolutely agree. And it really comes down to the specific requirements and, as Crystal mentioned, the use cases, because there are certain use cases that may or may not fit well today, or maybe not even on the roadmap yet. And those have to be analyzed very carefully. So leveraging, industry standard communication, APIs, the industry standard ways in which information can be shared is a key component. And then thinking about, where are you managing all of that brand of yours, right? Do you have a whole bunch of templates that are relatively static templates, or do you have the ability to dynamically generate that information based on a controlled source of your messaging? And is there a clear governance around which system or location owns what data, so that you can have one, right? There are a lot of different techniques and tactics, but it really all comes down to, with the right decision, is what is the specific requirements of need? What is the EMR or EHR being used? Because there's a wide variety, right, of what's available and what's not. So all of that comes into play, certainly.
Very good. All right. Next question, Shafiq, we're going to start with you. Patient engagement often lives at the intersection of operations, digital strategy, and IT. Who leads this evaluation process in your organization, and how do you ensure alignment across departments? I think that's one of the core issues here, is this intersection of IT and clinical leaders. You talked very eloquently, Shafiq, earlier. And first, Chris touched on this. He made the point about preparing the patient for the visit. That's a huge part of healthcare. Sometimes you need a lot of things in place to be done before a visit can be effective. Right? We want to do certain things today. In order to do those, we need certain things done. We need you prepared in a certain way. There's a lot of clinical nuance to understanding that. IT may help provide the tools, but to what degree do you need to have continuing, ongoing coordination? Because you're a physician, but many IT leaders are not, and there's a lot of clinical nuance here. I mean, as an IT leader, you just create the platforms and then the clinical leaders get to play with them and fine tune them? But tell me about that.
Yeah, so if you work somewhere long enough, you become wiser. And then if you make a couple of mistakes, you become more wise. So in the world that we live in, when we implement something, we had 28 electronic health records. We became one. We had 9 HRIS system. Now we have 1, right? So you have a different governance committee at that time when you do implementation of stuff, and you have a different working of doing things. Let me tell you what I'm trying to tell you. Then when you mature, you suddenly learn that certain things are not right. So you go to governance 2.0. In the governance 2.0, you start from the bottom up. That means the people who take the phone call and the people who manage the contact center and the actual doctors and nurses who actually see the patient and the clinics that works it and the nurses who actually do the thing. So what I'm trying to tell you is that you create the governance from bottom up till up to the IT steering committee. Below that, the EHR steering committee. Below that, there's a cross-clinical steering committee. What it does, everything bubbles to it, which allows us to understand what one hand does and the other hand does. Below that, there are domain steering committee. That means each ED, inpatient, outpatient, other places. So people talk to each other. So when you're asking about the intersection, if you process that and if you allow people to make most of the decision at the place where the problem is, because when somebody asks me about innovation, I say we have 16,000 innovators that work at Tufts Medicine, and we have 1,500,000 innovators that come to visit us every day, and those are known as the consumers. And they educate us, and we elevate our support every day as we interact. So that interaction allows us to understand what the need is. And then everybody participates in it. Then we go to the solution. And even before the solution, sometimes the the physician organization may bring somebody else may bring somebody, and then we have certain criteria in it. Hey, does it meet the certain needs for the patient? Does it have an ROI? Does it have something else? And that's how it builds up. So now I'm a more wise person by having the second time making it better when I first implemented stuff. So what I'm saying to you, brother, thanks for having this session, and thanks for having the great learned colleagues from whom I will learn, so
Yeah.
that they can contribute, because each one of us has become better and we are getting better every day. So the idea in the olden days when people were not aligned doesn't work anymore.
Yeah, it's interesting. So you know your point you're making, I believe, is that feedback is invaluable, complaints are invaluable. Every bit of feedback you get is an attempt or potential for innovation. So you want to be absorbing, all your patients, all your users, things they want to see improved. That's got to get into governance, and governance got to then make the changes. Not every complaint is going to turn into a change in process, but one, there could be patterns and some could be invaluable. So don't ignore those. Don't miss out on that opportunity. Chris, what are your thoughts on that concept?
Yeah, I agree with that, and I want to build on that concept of becoming wiser. So adding on to this is, in lessons learned over time. You mentioned, Anthony, early on, of does technology just turn on the tool and let people go and use? And we've seen that fail where people, and Crystal probably definitely will resonate with this, being the digital transformation leader, but IT, if we turn it on, people gravitate towards the way they've always done it, try to use the tool in normal workflow. But it's what really is to be learned from this and really to be heard, especially you're seeing a lot of this crop back up with AI again. Not that it ever went away, but the message I keep hearing around AI, and even on this conversation here, patient engagement, it's we need IT to come to the table and be leaders. We need technology to tell us and lead us on where is the application appropriate and where is it not. And I think that's, to Shafiq's point of becoming wiser, of lead the conversation, lead and partner with your operations team of how do you appropriately implement, use, optimize what's being installed, versus set it, forget it, and walk away from it. And it takes that tight collaboration, to Shafiq's point, with operations to really understand the problem. But as leaders in technology, we come back and say, this is how we solve that problem. This is the appropriate way to do that.
Crystal, what are your thoughts?
Yeah, I think you guys are hitting it right on the head. Change management is definitely probably 90% of any new thing that we put out. Getting people on board, whether it's the front desk person or the provider, that's the hard part of this. The technology is relatively easy, but also, everybody goes to a conference and they come back and they've seen 3 new things that they absolutely have to have. And like we've talked about before, you can't support all that, whether you're an IT organization or like I am, a side digital organization. And you have to really evaluate what the problem is that you're trying to solve. And is there a need for it? And can we adapt to it? And can we work it into the workflow without making more work for the providers? And hitting your patient and family access councils, making sure that you have providers in the loop, making sure that you have those front desk people in the loop, or the patient access center, depending. We do a lot of what we call big work sessions here, where we just bring everybody in a room and we're talk about, workflow out the entire process and say, where are the sticking points? What technology do we need to put into place to move that along? Should we? How much is that going to cost? What is the ROI of that? Or do we just let people do it? Not everything needs to be digitized. Sometimes it's just as good to leave some processes alone.
Oh, that's interesting. Tell me a little bit more about that idea, Crystal.
You could put in a really snazzy blah 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 several $1 million a year system, but A, if people aren't going to use it, or B, it's working just fine, and there's other priorities that you need to take care of, then you should gravitate towards that, not just because you never do technology for technology's sake, I think is what I'm trying to say, Anthony. You
Yeah.
really have to have a problem. You really have to know that it's going to be adopted. You have to carry it through if that's what's going to happen.
Very good. Gina, a question for you. You deal with lots of customers. There's this idea, the question on the screen here about the way customers might engage with you, do you see certain characteristics in customers that seem to be really successful, where they bring a variety of people to the table, or you're getting a certain level of engagement, and perhaps on some of the ones that aren't quite as successful, you also see certain commonalities?
Yeah, great question. And we've long seen that it's really a consensus type situation, anything that's at an intersection point like this. Depending on the use case, clinical or IT, or someone might have stronger weight
Mm-hmm.
in the decision making for sure, because it depends on the use case. And is this about scheduling or something that's not particularly um, sensitive or not? So I do think that that consensus view, and I like the approach that Crystal shared of having these big working sessions where you've got that cross-functional view. Really important to hear those different perspectives. And also what Shafiq said, that if you go closest to the patient and you're going down, you're talking to those who are communicating at that level or dealing with the issues that may come in regarding patient engagement challenges, you're going to learn a lot more about what those challenges are. So the only other comment, your second question about situations that haven't worked as well, I would say when it's not cross-functional or cross department, or it's not a consensus situation where one department, if you will, might just, to Crystal's point, you could end up with a technology for technology's sake if you didn't think about the holistic process and what's the end game. What are we trying to achieve? What is the organization or our customer trying to achieve for the patient and or the organization? And having those multiple groups together, that will bubble up and stay at the surface.
So may I add two things very quickly
Please.
after listening to Crystal. The things that I have learned, as I said, wiser, is adoption is key for the people who are going to use it. It has to be meaningful and pleasurable for them. And that part led to me understanding everybody thinks that AI is going to do great. I do believe in that. But we also need to have digital training and AI training. We do in-service for nursing, we do other things, but we have not as yet developed specific training for digital workforce. And that is true and needed. Similarly, if you do all that and the patient doesn't use your app, that means, like I tell people, when was the last time you call Apple's help desk how to use an iPhone? So what that means is that the technology should be democratized in a way that it is usable, it is meaningful, and it is pleasurable. And that only happens if you do that hard work, go to the Gemba, understand the thing, and the person you are building it for has to be part of it.
Mm-hmm.
So that's the part of getting wiser.
Yeah, I had an interesting conversation the other day, Shafiq, and we discussed we had to do a revenue cycle, CIOs being more involved in the revenue cycle, and how they really need to understand the process that they're trying to assist, and that to do that you have to be willing to learn, and to learn you have to have humility, which means you have to say I don't know. Right. And maybe you're going to get a look like, I can't believe you don't know this, but if you can't handle that moment, you're never going to be able to learn. You have to have the confidence to say, I know lots of things. I just don't know this, but I want to help. Right. So educate me. Yeah, that was around revenue cycle. And it could easily be transferred to patient engagement. And it could easily be transferred to many of these clinical nuances. For example, you're speaking to a departmental leader, and their patients are coming in for tests and they're not prepared. Well, how can we do that? Well, tell me what goes into being prepared, right? And so it's that going to Gemba, it's that going for every situation where people need help, it's deeply understanding it. Chris, your thoughts?
No, yeah, fully agree with you there, and really honestly nothing to add to that. I think your point was spot on.
All right, thank you. Crystal, anything there?
Yeah, I would just say that, what I've tried to do as we kick off these projects is get the people doing the work on the IT side to be part of the kickoffs and part of the understanding and the why. Like, why are we doing this for patients? Why are we doing this for the clinicians? They get used to setting up the EHR a certain way, and that's their job, but they forget sometimes, or maybe they're unaware of the downstream effects either for a provider or a nurse or the patient. And so for them to understand the pain points and be reminded and engaged in the process from that side, and not just, I'm going to do these setups or these workflows, but to understand truly why we're doing that, I think is just as important for something like this, so that they understand as well.
Yeah, Gina, is it a sort of a red flag ever when you're like, when are we going to meet some users here? Like, if it's like IT's doing the deal and IT's in all the meetings with you, and you're like, you guys aren't going to use this. So when do we get to meet the people? Because we want to work with the people who are going to use this. Is that a red flag? Have you ever seen that?
Yes, we have definitely seen that, and it is. So it can start that way though, and that's okay. But in order to have the patient-centric view and really understand what the end game is, and as Crystal noted, the why, it's critical. I mean, unlike internal business systems where you can do change management and you can do training for your team, you can't do that with your patients, right? You've got millions of them, across these various health systems. So usability
Mm-hmm.
is absolutely critical. And so I'd say it even goes beyond the internal team's perspective of what consumers and how consumers will consume or use the tool, because you can't train them. It has to be so simple and straightforward, and as Shafiq mentioned, meaningful to the user, and then they will adapt. And thankfully, we've got Apple and other technology that's led the way to help people learn how to learn faster with digital technology. But it doesn't, it still means you can still create an unusable product if you don't focus on it.
That's a great point. And Shafiq also used the word pleasurable. So it's got to be pleasurable. It can't just be usable. It's got to be fun. Um, no, it's an excellent point. And we've probably all tried different tools that were given to us where we just threw in the towel and said, "I'm going to speak to a representative. I can't use your thing here. I don't know how to use it." So, all right, very good. I want to hear what you folks would like to ask each other. Um, Gina, let's start with you. Do you have a question for one or more of your co-panelists?
I do, and I'll just open or ask it broadly, and anyone
Mm-hmm.
who wants to jump in. So I would love to know what you are most concerned about when you think about AI being applied to these various products that might augment your processes. What is the greatest concern you have around leveraging AI?
Uh, Anybody want to jump in, or otherwise I'm going to call on someone. All right, Crystal, it's you. You're up.
Ouch. Okay. I think that first of all, making sure the safe, making sure, we have a governance committee that actually looks at, how often um, the models are being updated, things like that. I think that AI or any program that we're doing this where we're trying to augment the workforce with some sort of technology needs to be thought of as another employee on your staff. And you need to review it every year. Is it still doing what we wanted to do? Do we need to tweak it? Do we need to change it? Do we need to put it on a performance plan so that it can be updated to meet the needs of our organization today? And I think too much, I think, Chris, you were the one who said, set it and forget it. Like, too much, that's what we think we're going to do with these tools. And that's not the case anymore with AI and the changes and everything. The voice might change for a voice bot. The AI models might change and it can do faster, different, or maybe you should tweak it a little bit. And I worry that we'll have so many of these things that we don't take time to go back and circle back and reset appropriately.
Great point.
I,
Shafiq?
So I love AI. There is no doubt about it. It's like you have a child, you love it. But as the child grows, you have to guide it, monitor it, teach it the values, the ethics behind it. When they become teenager, they become a little extraordinary. So you have to understand that. So AI is a good thing, it's not a bad thing, but the same thing as I said before is that just the IT guy knowing AI is useless. So everybody needs to know what it is. And like Crystal said, that you have to treat it as an employee. I like that idea a lot. Not only that, but also you have to understand it's a very powerful tool. And AI is not just generative AI. It's not just multimodal AI. So now we are using agentic AI, one ring to rule them all. We call all other things that are happening. So we are using AI like a tool for our physicians to dictate or to talk, right? So somebody has to look at it to say that whatever they said, it is there or not. So we didn't just roll out ambient to 5,000 doctors day one. We went with 60, 30, and they all verified, checked it. And then the finance people made sure that the necessary codes are there. And if it made any mistake or there was any hallucination, we'll let the company know, make it better. So it's a continuous making it better. And then sometimes people say human in the middle. Well, human in the middle is not the only way to do it, because I want the human in the beginning and I want human in the middle. I also want human in the end and human to come back because it's my teenager. You understand that? So what I'm trying to tell you here is that it becomes more okay when you're doing administrative work because there is no lives dependent on it. But it's got money, it's got things in it. But when it becomes clinical, it has benefits, but it has to be within a guardrail. And sometimes, even when you're running a sepsis model or those things, they have to be monitored more carefully. It's no different than any IRB that goes through for research. The AI tool has to go through the same IRB evaluation. So it's no different. The only reason it becomes different is because we have not explained it, or we have not understood it, or we have unleashed it without thinking. A Copilot is good, but Azure AI is better. Multimodal AI is good. Gemini is good. Entropy is good. They are all good. But here is the funny part that nobody tells you, that all of them do certain things. None of them do all the things.
Huh.
So then you find out that there are so many AI tools for different things and for this specific things. So I'm an AI virtuoso. That's my title, right? So now I'm telling you as a chef of AI to cook it, how to cook each part of it. Then you find out, oh, like I told my my two children, there are three people you need to talk about your career. One is Gemini, the other is ChatGPT, and third is Mr. Perplexity. Okay, and then come back what you want to do for your career. So different AI tools do different things. That's why one of the roles for the digital information officer, myself, we are making ourselves more and more knowledgeable.
Yeah.
So that we can guide our operational leader and our clinical leader to understand how to use it. So we have a lab, we have a simulation lab, all those things people are doing. So we're not afraid of it. We're just trying to make it right.
Wow. That's good. A lot of good stuff there. Chris?
Yeah, a lot of great stuff. And Crystal, I like the way you relate it to an employee. I think that's top of mind for me is always value up front, and continued value of whatever you implement. And Gina, you said at the beginning of this, you talked about technologies against different sets of data with different outcomes. And I'll throw out a concern of mine, building a little bit on what you just said, Shafiq, here and open this up for reaction or if I'm wrong or off base. But when we look at kind of an omni-channel experience, whether it's a contact center or some type of digital tool engagement, if we're feeding that with different third-party solutions or different technologies, my largest concern there is it's gonna give different answers, even if it's on the same set of data. It's going to have a different experience, different look and feel. But I think that's one of my top concerns, and that it's more of a hypothesis than proven out. But am I on base, off base with that?
Yeah, I think the more you put in the mixture, the more difficult it becomes.
Yeah.
Therefore, you need an AI to control the AI so they give the same answer. So I'm just telling you that. So therefore, you have to, that's why I love agentic AI now, because it does the things I want it to do for me. You are 100% right. You have to ultimately choose one vendor to sit on top of your EHR, whatever it is, so that you have the consistency. You're 100% right, Chris, my friend. I think you are onto something very important. That's why this is what, Gina, your question is when you're asking that, what do you do with AI? The thing is that we know that it will be here now because we have robo taxis. It's not going to go away. We just have to become better at it. That's what it is. And we are getting better at it, but we can't get better at it with a traditional approach. Then we'll have a traditional thing, never works. The growth is exponential, but the guardrails are important. Guardrails are very important. So that's why I like Gina and Chris what they said to us, that like operational people, we have concerns too. Therefore, we have to become experts at it, and we have to actually try it out in a contained environment before we unleash it. But even if we unleash it, there are guards, safeguards, checking, like things that happens every day. For example, if you use an AI, like nowadays we have cybersecurity, right? So when a bad person attacks you, what the bad person does, it, like we have scheduled backup jobs. We have scheduled jobs. They put in a scheduled software in your background. There's only one difference between that and everybody else. The difference is they also add a line of remaining permanent. That means, what's the word, starts with a P, that they cannot be taken away. If you write a logarithm of AI, it will find it in 2 minutes, the persistent, the backup job, the persistent job that the bad guy left. For you to find out yourself, it will take you 3 years or 3 months or 6 months. But the AI will find out in 1 second. So there are, but if you know those examples and use cases, which we are using and other people are using, that how do you find a persistent threat environment in your place if you write that model? I'll shut up.
We just got into cybersecurity, so
No,
it
man,
was good
because,
though. It was good
because
though.
I'm telling you, it's such a valid question that you have asked about patient engagement, giving people information. It cannot be totally automated yet. Yet we want it to be.
That's a lot of good stuff there. Yeah, I'm just trying to mentally absorb it. Crystal, anything on that?
Sort of a twist on this, if you don't mind, Anthony, but
Yeah.
if we think about how fast AI changes and how fast these vendors are moving and how often you have to revisit or whatever, how do my friends deal with that as opposed to the structure that IT departments originally lived with, right? If you put in Epic, you know, or ERHR or Workday or whatever, you know that 30 days before you're going to go live on June 30th, you have to finish testing. And 30 days before that, you're looking at the release notes. And it is very cookie cutter and you always know what you're doing. So you can say, oh, we're going to do release 6.7. I'm going to need these many people for these many hours. And it's just set in stone. But when you have these newer products, it's, I'm going to try for 4 groups. I'm going to try for 10 groups. I'm going to put it out for this division, and then I'm going to have to repeat it for another division. And that second division might need a tweak in the API, or it might need a tweak in the download that the AI is ingesting. And that means back and forth with IT. IT traditionally cannot handle that. So I'm curious to know how you guys are overcoming that. Because I'll tell you, we struggle with it. We don't know how to manage that time yet. We're trying, but we're not there. It's not smooth.
She is 100% right. So the thing is, you need a chief AI officer. Basically, what ultimately is happening to us, we are becoming a data company. Whether people see it or not. When I built my lake house and I put a semantic layer and I became AGI ready, that was 3 years ago, right? So I knew that one day this will happen, but I didn't know, I can't say that I knew that it'll become so fast. So to deal with that complexity, your informatics department and your AI department and your digital transformation department have to work together really fast, because IT is slowly and gradually becoming an infrastructure department and is becoming a network department and is keeping the trains on time department. That's what's happening without any of us openly saying this. So since I talk a lot, so I just said that it's a big deal. It's a big deal, and companies that recognize that they need to have a digital workforce. I cannot say that again so many times. An AI workforce, people who understand that, recognize that, and on top level have to be people like Gina, like Chris, like myself, who dedicate their time in seeing the new technologies coming in. 5 years from today, technology will be totally different, 100%. And now, like for example, everybody talks about DNA. I talk about epigenetics because your DNA will not change. Your epigenetics does. That will decrease your age. So Anthony, one day we can talk about aging and I'll talk about it. So to understand that complexity, you need PhDs, you need scientific people who work with you so they can deal with it. And if you don't, then you need to have a company that deals with it to help you, because it is getting faster, quicker, and more complex.
All right, we're going to have to go for a last round of final thoughts, but Shafiq, I just want to make sure I understand your point about the change, sort of the changing role of the IT department. It sounds like previously was more about control, running projects, control. And now we're talking about empowerment. We're talking about, because we can't control this thing of AI and use it. We can't control that in IT. We need to put the infrastructure in place and empower with guardrails. But it's sort of, is that the fundamental shift you're trying to describe?
No, you can have in the IT, nobody's stopping you from putting wherever you feel like, whatever the institution does. What I'm trying to tell you, you have to emphasize on it, because if you don't emphasize on it, and if you don't have the right skill sets in it, you will never be able to advance it.
You mean on the user side, like on the employee side, like a digital workforce?
Both. You need
Both sides.
employee side to understand, because they're the one who's going to guide you, right?
Right.
But on the IT side, or you call traditional IT side, that's why you have chief digital information officers. That's why you have chief AI officers. Therefore, that's why you have new kinds of people who are new job titles are emerging to manage that. But what I'm trying to tell you is that you need those skill sets.
Yes.
And
yes.
where you put it, that's up to each individual institution where you
need
work.
the skill sets. Okay, so that's good. I appreciate that. All right, we're going to have a final round of comments. We'll get back to our core topic here, which is the idea. Listen, we got to go where the train takes us, because this was interesting. But we're going to get back to our core topic, a final round of thoughts. I think the core issue here, which we touched on earlier, is that decision point that you feel that we need to go outside the EHR suite. And there's so many factors that come into that for any piece of technology. The piece of technology you're looking at, the security of it, the integration ability of it, the current products you have, the current EHR offering, the roadmap, the users and what they're wanting, where your strategy is. There's a million things that'll go into that algorithm, let's call it, in order to make that decision. But fundamentally, we should not be completely beholden. No one's saying they are. Even Chris, you talked about there is the point when we need to go outside, and if you're not willing to do that, then you're not innovative, right? Then you're sort of vendor captured and all that. So let's just talk on that. Any subtleties you can give me about that decision point, weighing that point, and when it is time to go outside of suite. Chris, why don't you go first?
It's yeah, the decision point of it is obviously when there's a need. The offset to is the cost. Internally too, we even talk about when is it time to come back in. So we see this often. We go by a third party, Epic catches up in case of many things. And when is the right time to sunset that product and come back in? So maybe back to Crystal's point of treat it like an employee, even our portfolio of applications, when is that value best served somewhere else? So you can't buy it and say it's forever, and necessarily you got to continually reevaluate where things may be best lived long term.
Yeah, it's Crystal, everybody loved your point about AI being an employee, and all products are employees, and they get performance reviews. They need to get regular performance reviews. So, your thoughts on that decision point and when that tips over into needing to go outside a suite?
I think that the most important thing is the patient, right? And so they want seamless. They don't need flashy. They need something that works. So simplicity and the integration is always going to win in this case. So is it 3 steps? Am I going to feel like I'm going from one system to another, or is everything going to come across? Do I have to re-log into something in order to access something else? That's a dissatisfier for our patients. So you really have to think about how you're weaving things together in order to make it better for the patients and not putting more work on the providers at the same time.
Very good, Shafiq.
Yeah, both of my colleagues have very nicely said. So the only thing I can add to it is that we do app rationalization. Now we have to do AI and chatbot rationalization.
Yeah, yep.
So there is a process to it, and the idea behind is very clear. So what our mission and vision is, and what our demand is from our consumers, because they are demanding also on things, and they are much more into AI than us. So if that's what they want, and everything has to be in one place, and everything has to be smooth and easy and pleasurable and meaningful, and all those things you want, most important what they want is to get a good care. What they want is to know that we are there for them. So as we are building this kind of information back and forth, we have good things like you go to a couple of hospitals and clinics to learn about certain things. So when you're asking when we make that decision, if our EHR is not providing those things that the consumer needs, we have to go get it. So that is the first point. Second point is that when we get it, it has to work for our staff and the employee who are using it. And third part is that it has to become better for our physicians and caregivers so they get the same information. So the criteria for getting any new equipment or new thing have not changed. It is the same thing that we do. Is the patient safety, is the regulation, is the ROI, is the same criteria. It's just a different name that we are giving patient engagement. You see?
Beautiful. Beautiful. Well done. Thank you very much. Gina, we'll give you the last word.
So, first of all, thank you to the panelists. This is, as I mentioned in the beginning, I was excited to listen and learn. This is excellent. I'll just say that, research shows that when patients receive clear, actionable instructions and personalized outreach, their trust in their provider increases, right? And that trust creates a pathway to loyalty, long-term engagement. That's what, health systems want. And that's going to drive better business outcomes. But it also really, if we just bring it back to the human here, it makes life easier for all of us. Healthcare is a scary journey sometimes, right? It just is. We don't understand it, especially those of us who aren't clinical. I'm personally inspired by today. I'm excited that I have one of my kids is going studying to be a nurse. So she's one of those digital native people who's going to be entering the workforce. And I'm just really excited about where this will go. Thank you again, Anthony, and for the panelists on sharing your insights. It's been very great. Thanks.
Absolutely. I couldn't agree more. They've been wonderful. Regarding continuing education, you can use the final slide in this deck. If you want to work with us, you can reach out to Nancy Wilcox from our team. You'll get an email when the on-demand recording is ready for viewing. If you want to sign up for additional webinars, they're on our site right now. So I want to thank our tremendous panel, Chris Akeroyd, Crystal Broy, Dr. Shafiq Rob, and Gina Armada, and MHC for sponsoring and making this possible, and you for attending. And with that, everybody have an absolutely wonderful day.
Thanks all.
Thank you.
Bye.